Alrighty, and we have 5:05, so I think this is probably a good time to get going. People can always still log in at any time. So I just want to welcome everybody to our first pediatric brain aneurysm AVM webinar. For far too long, something, the foundation does a lot with support, education, and awareness, advocacy, and research funding. But something that we've really always been lacking is paying attention to the pediatric community. And, it's easy for me to say, but I know it's super hard. The one thing that has always resonated out there in the pediatric community, and a lot of medical professionals say it all the time, it's something that's very rare in children. But if you're a family impacted, that's just not the message we want to deliver. That's not the only thing we want to do. For families and communities affected by pediatrics, being affected by this disease, whether it's aneurysm or AVM. So this is just the beginning. This is our first step into providing more awareness and education around this disease in the pediatric community. So I'd like to introduce our panelists. We have Todd Helton, who's Ellie Helton's dad, and with the foundation Like Ellie. Ken and Daniel Thrush, dad and son team. And they also are with Daniel's Music Foundation. We have Dr. Deanna Sasaki-Adams from UNC Medical School, also a researcher. We have Dr. C from Boston Children's Hospital and Dr. Ubeda from Dr. Children's Hospital. So welcome to everybody, and thank you so much for being here. So for our first question of the evening for Dr. Sasaki-Adams, who is the most likely demographic to have a brain aneurysm? What facts, signs, and symptoms are most important for the public to know regarding brain aneurysms?
Well, thanks for having me here. And, brain aneurysms are difficult in that they don't give a lot of warning oftentimes, and they're not quite as common as some of the other devastating diseases that seem to get a lot more recognition in research funds and other things. But, brain aneurysms tend to hit people when they least expect it, because they don't always give a warning sign. It's not like you develop a rash and then suddenly your aneurysm ruptures. The key folks, the most common age is around the 5th decade of life. So not, pediatrics are more rare, but I'm glad we're discussing it because it, they can be a bit different, and I think it'll be important to kind of listen to your gut and go through the workup appropriately for them. But when you're in your 50s, you're hitting people in the prime of their life when they have families and are key folks, and so it's also, no matter when it comes, it's important to, if we can find them ahead of time, it would be beneficial, because once an aneurysm ruptures, we think there's 30-40% mortality rate, and that doesn't necessarily change despite what you do after it ruptures. Key issues: women are a little bit more likely than men to have aneurysms. We think about 1.5 times in general. That's what I quote my patients. And folks that have a family history are more likely. So if you go back and you think, oh yes, my mom, my aunt, my grandmother all had an aneurysm, then it's better to be on the lookout. And there's actually, unfortunately, insurance companies sometimes won't screen for you unless you have a family history with at least one first-degree relative and then an associated symptom. Sometimes if you have no symptoms, they want 2 first-degree relatives. And then smoking and hypertension that goes untreated are 2 of the other sort of risk factors for aneurysms.
Thank you very much. Our next question is going to be for Dr. C. Regarding pediatric brain aneurysms, how do the statistics differ, and are the symptoms the same? And what about AVMs in children?
Thanks so much for that great question. It's interesting because, as Dr. Sasaki-Adams mentioned, aneurysms we think of typically in adults, but there are some very critical differences that come up when you think about children and children with aneurysms and how it manifests, and also how you manage them after they are found. So there are some academic type of data points which don't end up mattering to each patient with aneurysms, but that gender difference where more women have aneurysms than men, that's a little different in children because part of that effect, we think, probably has to do with hormones over time, and that's less present in children. So actually we lose a little bit of that gender difference, and there might actually be a little bit of higher risk for boys than girls to have aneurysms. But ultimately, those kinds of nuances aren't quite as important when you're the one who's already had an aneurysm and it's been found, right? But the things that are important are what causes that aneurysm. And ultimately, we do know that there's different reasons for aneurysms in children than there are in adults. So for example, things like what we call arteriopathy, so diseases of the vessel or the vessel wall that are related to genetic ability to heal a vessel wall, can be more likely to cause problems in children's vessels and manifest as an aneurysm early on in life compared to things like smoking or high blood pressure, which take time to accrue. And those are some of the drivers that we see in adults with aneurysms. It's interesting because that also means that those same patients are a little bit more difficult to treat because those vessels are more sensitive, meaning that the risk of treatment is a little bit higher. And that needs to be taken into consideration when you're talking with your doctor about how to take care of your aneurysm. It certainly doesn't mean that aneurysms shouldn't be treated in children, but I think that kind of balance is important to consider. And that means that you want to have an interdisciplinary team, as all the big centers do nowadays, where you have endovascular treatment options, open surgical options, and cautious thinking about maybe certain aneurysms don't need to be treated. So some of the literature published by groups who have really compiled a lot of literature over the years and looked at everybody's experience, because any one center, for example, at Boston Children's in the last 10 years, we've seen about 120 aneurysms. That's not enough to really make generalized statements, right? Because each of those aneurysms looks a little different. But when you then combine all the centers from different countries or from different states in the United States, you can start to make some statements. So when we look at that, it's interesting that a lot of aneurysms that show up but don't have a bleed event are a little bit less likely to bleed than you might expect from an adult aneurysm. That being said, that's very limited follow-up. So for example, those studies really report an average follow-up of only 4 years. But we know that in kids, we're talking about decades of protecting someone from an aneurysm. So we need to proceed cautiously, even with that kind of data. Other nuances involve kind of where the aneurysm is and what happens after the aneurysm bleeds. So you asked about symptoms and how it differs in kids. As you can imagine, it's very difficult to tell in a kid who is 1 year old what's going on, why are they upset? And that leads to a slightly different pattern. A lot of those children a year or under, or even probably up to 5 years, we find them typically only when they had a bleed event. So there's a much higher bleed rate. Up to 3/4 of aneurysms are found only after a bleed event in those children. That being said, those children certainly have a very strong capacity to recover, as my colleague, Dr. Tikanen, will kind of talk about as well. But there are some other nuances. So the children will tend to present with seizures or kind of drowsiness or nausea or vomiting. And those often happen in adults as well. But those can be some of the signs that are predominant in children because we don't pick up things like subtle eye movement changes that an adult would tell us they notice is going on differently today compared to yesterday.
And just one more thing about how do AVMs differ in children, or is it a similar pattern?
I think when we look at AVMs in children compared to adults, and just to break it down into the fundamental, when we talk about the aneurysm, that's a blister on the side of the vessel, whereas when we say AVM, that's really shorthand for arteriovenous malformation. And we like to think of it as an abnormal connection between the blood flow that's coming in the arteries and the blood flow that's draining. And there's different ways in which that abnormal connection can exist, but those have a similar risk of bleeding and causing hemorrhage or a stroke as an aneurysm might. And those are a little different than aneurysms in that, yes, there can be this group that presents with bleeding, but sometimes those can also have symptoms from irritating the brain around it. And because those can be in different areas of the brain than aneurysms can, their symptoms might be a little bit different. But I don't personally see a big difference in how they present in children than in adults. So things we think about are weakness or numbness particularly on one side of the body or one limb, but also unusual things like recurrent headaches or things like seizures. So certainly AVM can also be very tricky to diagnose and pick up on, which, is certainly one of the topics that is going to merit further research and further thought amongst the community, and how to implement a good way of picking these up as early as possible.
Thank you, Dr. C. The next question is, misdiagnosis is a big problem in the general population. Is it the same with the pediatric community? And what is being done to address this? So I'll start with Dr. Sasaki-Adams first.
Yeah, I think misdiagnosis can be a real challenge in that it often takes a while to get the workup that will show an aneurysm. If you get a plain CT scan, you often will not see an aneurysm. So I've had a lot of folks come and say, well, I had a CT scan after I had a car accident some years ago, and why didn't they see this? It's because in most cases, it doesn't show the blood vessels clear enough to show that abnormality on the blood vessel. So you really need a study that's going to look at the blood vessels in particular, either a CT angiogram, an MR angiogram, or an angiogram where we go through the blood vessel in your leg or your arm to take pictures. The other issue, I think, is because a lot of things are kind of vague, especially in the pediatric population. It's very hard for children sometimes to verbalize that something's different, something's not right, and you go down through even in pediatric migraines can sometimes present with just profuse vomiting for no good reason, and so it's not a clear-cut event oftentimes that leads to the diagnosis, and so it can take a long time for diagnosis to be made with a pediatric aneurysm or AVM. I think seizures are much more, you see AVMs present more commonly with seizures, I believe, than aneurysms do. Usually if an aneurysm is going to present with a seizure, it's either because it's a giant aneurysm or it's had a rupture and caused irritation to the surrounding brain. I don't know if Alfred has anything else to add in the differences, but that's what I think.
Yeah, I think I completely agree. It's extremely challenging, and even in the adult population, that's one of the fundamental reasons why the Brain Aneurysm Foundation has all this strong advocacy and needs to continue to do its work, is because so many aneurysms can be missed or misdiagnosed, and it's just amplified in the children because it's even more difficult in this population to find a smaller needle in that haystack. But really having that discussion and sometimes just asking the question is all it takes. So having that discussion with the healthcare provider, because when Dr. Sasaki-Adams or I are in the emergency department or hear from other providers, it's really just they have a question: is this something to be thinking about? And then we can further discuss that and consider whether there's imaging. And I think in the past few years, we certainly have been pushing more and more for children to get imaging that's appropriate to them. So many providers worry about radiation in children, so avoiding CT scans. But actually, we're fortunate, and radiologists around the country are developing sequences that can be effectively used to look at brain tissue and really potentially even diagnose aneurysms without that, using more and more MR techniques. And MR is becoming more and more available as well. So that's certainly one way that we're able to pick up more of these aneurysms earlier nowadays.
Great. Thank you both for that. The next question: what are a parent's initial reactions when they are first told their child has a brain aneurysm? And we'll start with Todd first.
So thanks, Christine. So, just really quickly, if I could tag on to what the doctors were talking about in the last two questions. For us, for Ellie, and Ellie passed away in July 2014 at the age of 14. We did not know she had an aneurysm, but she had headaches, she had ocular migraines, and Christine has heard me say this before, but the doctors just didn't have enough time to get far enough down the checklist to get to aneurysms, because she's a 14-year-old kid. She's going through a lot of changes in her body. There were concerns that it was hormonal or different things like that, but nothing had been severe enough until the moment of rupture to really stand out to any of our pediatricians or our eye doctor or anybody like that to flag that. So they are very very hard to find in kids. And Ellie, at 14, she's able to verbalize those things, but still, there wasn't enough evidence there to really go directly to this severe of a situation. So thank you for letting me add that on. So I think, for us, when they did that CT scan at the hospital that morning and saw it ruptured, Ellie's aneurysm ruptured on her second day of high school, ruptured while I was getting her out of bed. And when they did the CT scan and saw the bleed, then they really had strong suspicions. But unfortunately, we were at a place that the hospital didn't have pediatric neurology, so we made the trip over from east side of Raleigh to see Dr. Sasaki-Adams at UNC and her wonderful team. So for us, it was a lot of shock and surprise because the only person we knew who had an aneurysm was Ellie's great-grandmother, who passed away in her 90s with an unruptured aneurysm. That had nothing to do. She basically died of natural causes. The aneurysm did not rupture. But that's the only experience we'd had with it, and certainly not to think of it in our 14-year-old daughter. So a lot of shock, a lot of surprise, a lot of awareness pretty quickly about what we didn't know about it, what a brain aneurysm would be, and a lot of conversations then with the team at UNC trying to educate ourselves. And okay, what does this look like? What does this mean? And what is the pathway that we're looking at here? And I remember having a conversation in the PICU with a couple of residents about 3:00 in the morning, what turned out to be the day that Ellie passed away. But they were preparing me for life going forward, that Ellie would not be the same probably if she survived it. And all I heard was going forward. I didn't hear the part about if she survived. So, to me, it was really like embracing that part. Okay. And then trying to find out about, okay, what do we need to consider going forward? Because then I figured that we probably live about 30 minutes from the UNC campus. So we were going to be making a lot of trips to UNC in the coming weeks. That's where my brain went. I didn't really even consider the possibility that she wouldn't survive it. When she was in surgery and being coiled, Dr. Sasaki-Adams was gracious enough to come and sit with us in the waiting room for a while. She even drew a little diagram. And I still tell her I have that diagram still, and what this all looks like with the coiling process and the aneurysm and all those kinds of things that go into what was happening to her at the moment. So we felt really informed, but it was like drinking from a fire hose, with also all this stress and the tension and concern for our two other daughters who were younger, and family coming in from all over the place immediately to be with us. There was just a lot going on, and it just got bigger and bigger and bigger to us. And so, I think those are the things that we were dealing with in the initial hours, and then as time progressed with Ellie's treatment. So.
Thanks, Todd. Now, Ken, would you share your thoughts?
No, sure. Thanks. I mean, our family was in shock because, Daniel, you were having headaches, right?
Yeah, I was having really bad headaches for a few weeks before, and my parents brought me to my pediatrician, and he thought that they were just migraines.
Which is common, on that side. He did have a referral saying, go see a neurologist for migraines. And Daniel was very competitive, both in school and sports. So we looked at it as, is he pushing himself too much? Are we pushing him too much? So we were looking at things to try to relax, the pressure that he was under, taking into consideration his personality. So there were days when he seemed fine, and then there were other days where he just couldn't lift his head out of bed, and he was vomiting, like the doctors were saying. And so the day that the aneurysm ruptured, you were playing.
I was playing basketball one Sunday afternoon at my school gym, and I took a shot, and then I came running off the court holding my head, and I collapsed in my dad's arms.
And so we were fortunate living here in New York City to go to Beth Israel North, which was founded by a neurosurgeon, Dr. Fred Epstein, and also Alejandro Berenstein. And they took him right in. And when they told us that he had an aneurysm that ruptured, it was shocking because we were on the track of migraine. Okay, that's when Nancy, my wife, and I were thinking. I did appreciate both Dr. Berenstein is a neuroradiologist, and and Fred Epstein is a neurosurgeon. I love the fact that they were very clear on how serious Daniel's situation was.
Yeah.
I still remember, this was 25 years ago, and I still remember Dr. Berenstein said, look, your son is very sick. You either let me go up through his groin area to put a platinum coil into the bleeding aneurysm, or you take the pictures and go somewhere else. I have to do it right now. So the care that we got was exceptional. But prior to, it was, look, parents don't want to believe that their child is sick, their healthy child is sick. I don't think adults want to believe that they're sick. That's why we don't go to doctors, right? We keep Googling things. And that's why we're so passionate about being here tonight, is to forego ego, forego those thoughts that it's not going to happen to you, and just be smart. Just be smart about it.
Thank you, Ken and Daniel. The next question, and Ken, we'll just go right back to you before Todd. What do siblings ask, and are they concerned of it happening to them as well?
You know, let's see. My son Michael is on the watching in. So Michael is now a neuropsychologist, but he was 9 years old when Daniel's aneurysm ruptured. It was one of the hardest things to have to say to him, that Daniel might not make it.
Yep, that I was so sick.
And so the doctors were really, really helpful in that situation. I spoke to Michael and I said, he's really sick. We didn't bring him to the hospital for the first few days because we didn't think Daniel was going to make it. The doctors didn't think Daniel was going to make it. They were optimistic. They were always, we're doing everything we can, but the bleed was so severe. And it was hard speaking to a 9-year-old who looked up to his brother, and after the aneurysm, there was a role reversal. All of a sudden, Michael became the older brother to Daniel. But what they did at the hospital was really beautiful. The intensivist said, I want to speak to Michael before he sees his brother. And he spent 20 minutes with Michael with a model of the brain. And he said, this is what happened to your brother. This is what you're going to see when you see him the first time. And Michael, that really helped Michael in that transition. And it was so funny because they had put a hat on Daniel's head to hide the drains in his ventricles. And I said, Michael, what did you think when we got out? He goes, the hat wasn't on his head fully. And so it's funny, the observations that people get.
Yeah.
But, Michael, to answer specifically your question, we were all concerned about Michael. And so we went through an extensive genetic testing. We went through MRIs with contrasts to make sure that, to find out if any of us had aneurysms. And Michael's handled it beautifully. Michael, I can't see you, but you know how much we love you.
Yeah.
Tell him what he does now.
Oh yeah.
Yeah, tell him what Michael does now.
And now Michael's actually a neuropsychologist.
And he tests, right?
Yeah, he tests the New York Giants for concussions.
Concussion protocol.
Yep.
So that's a shout out to you, Mike.
Yeah. You go, boy.
Yeah.
Uh-huh.
Thank you. Thanks, guys. That was great. And then Todd, the same question to you.
Well, Grace was 10 and Anna was 7 when Ellie's aneurysm ruptured. As I described, we just come back from vacation. School had started, so the girls were all riding a high on this, and then all of a sudden, the worst thing imaginable happens with their sister going to the ER. So, it was something they don't understand, and something their parents don't understand either. So we kept them away from the hospital the first day. They were with friends. They were able to spend the day in being distracted with things to do and things like that. And then as our family started arriving, people were my parents and I think Karen's younger sister were picking them up from where they were and bringing them home and things like that. And so we brought them into the hospital on the following day. That was a Wednesday, and they spent most of the day there. And of course, that's about probably late morning on that day was when we found out Ellie wasn't going to survive. And one of the just incredible things that happened in that our worst moment was, and Dr. Sasaki-Adams can probably speak about this group more than I can, but it's this team of young people showed up out of nowhere, kind of swooped our girls and their cousins up and took them away from us and got them busy doing activities and kind of helping them start the transition of what was going to happen, and in using those different activities to educate the girls and prepare them for what was ultimately going to happen at the end of that day. I just remember that being so amazing and feeling so blessed that we had those people there to help our girls transition in a much better way than we ever could have on our own. But the girls did have questions. They wanted to know more about what was happening. Why was Ellie sick? Would they get this? Would they be sick too? Was she going to die? Those kinds of really hard questions. I remember Grace, our then 10-year-old, standing at the foot of Ellie's bed, just bawling her eyes out, begging Ellie not to die. And just those kinds of moments. You really have a different perspective when you talk about the things that impact you and the things that impact your kids, and how those surface. And it's a really powerful moment, and not always in a positive way, but but we really wanted them to be there and to understand and to have a chance to spend time with Ellie in her last hours. And everybody was able to come into town except my sister and her family. My sister had some health problems at the time, but Karen's whole family was there. My parents came into town immediately. And so we were able to let the entire family spend time there. PICU waived all the rules about the number of people that could be in a treatment room. And we just had this togetherness, this time together as a family with Ellie. And, it's a sad memory, but it's a memory I'm glad we got to have for the girls, for their grandparents, their cousins, all the people that we could have there, and just the love. And one of the things Ellie had been preparing with the church we attended at the time was she was preparing to be baptized. And so our minister and the youth minister showed up at the church, and the chaplain from UNC was there with us, and we decided we would have her baptized in the room before we took her off life support. And I just remember all of us jammed in this little room, circling her bed and holding hands and praying and watching the baptism taking place, and how special it was for us to know that was kind of one of her final wishes, and we were able to make that happen in those moments. And I think it was good for the girls to see that, because a year later they both got baptized because their older sister, that was a big point in time for them in terms of them doing that at that point in time, because they saw their older sister do that. And, just the impact that those moments have. And look, we've had our share of very rough times since Ellie passed away, all four of us. But when you have that conversation that there's an aneurysm, I'm sure Ken and Daniel and their family have had their share of those emotional trials too, that probably aren't a whole lot different than what we've gone through, other than the fact that, they still get to hug Daniel and those kinds of things. And I think that's a blessing for them. And, but you kind of get that sense pretty early on through your own experiences and what you hear from your kids and see from your kids and others, that life's different now, regardless of the outcome. And so that's what you start prepping everybody for as well.
Thanks, Todd, for sharing that. I appreciate it. Daniel, the next question is for you. What was it like for you when you first started your recovery journey? And what were your biggest challenges when you first came home from either hospital or rehab?
Okay, so what you might notice is that sometimes my dad will prompt me. He'll give me like the first word or two because I sometimes have short-term memory issues.
But it's all
in here. Sometimes it just needs a little push to get out.
And so when you first got back, right, outside, you want to repeat the question, Christine? That would be great.
Mute. So Daniel, let's go back to that question for you. What was it like when you first started your recovery journey? And what was your biggest challenge when you first came home?
When I first started my recovery journey, the hardest part was just getting out of my wheelchair.
And how about speaking?
Oh yeah, yep. Yeah, when I was at Rusk one day, and I was still whispering at that time, one of the nurses put me in the shower and she put the water on too cold, and I started to cry, and that got the air over my vocal cords. So I went into my coma talking like a little kid, and then I came out talking like this. So my parents thought that I was like possessed or something.
I think the hardest thing for Daniel was just getting back your daily living act, walking and
Yeah,
walking
and talking.
Yeah, I mean that was the hardest thing, just to see Daniel. But the thing that we did was we developed a mantra, right, Daniel? What was it called? Mile?
It goes mile by mile, it's a trial. Yard by yard, man, it's hard. Inch by inch, it's a cinch. So that means just keep trying different things. You never know what's going to stick.
And keep at it, right?
Yeah, definitely.
And you tried so hard. What happened 10 years after you got out of the...
Actually, 10 years after I got out of the hospital, I completed the whole New York City Marathon, all 26.2 miles. It took me like 7 hours and 45 minutes, but I finished.
That's amazing.
Thank you.
So the next question is for you and your dad.
Oh, okay.
Share what role music played in your recovery and how you would like to see music shared more commonly as a recovery tool, particularly for the youth.
Well, Daniel was always musical, right?
Yeah, before my injury, I used to play the guitar and the trumpet, and since I've taken up the keyboard and I sing.
I think what Nancy and I realized, we were just trying to make sure Daniel had a meaningful life and he found something that he loved. He was different. Like Todd said, our family was different. It was never the same. So we just kept exposing Daniel to different things to see what would connect. And what we realized with music, first of all, we researched it, and the claim is that it activates more parts of the brain than almost any activity. And we saw Daniel took to it. But what was amazing was that even though Daniel has short-term memory...
not with music. I could listen to a song once or twice and then somehow remember all of the words. So even in my short-term memory issues, the music is still getting in here somehow.
It's actually amazing. I mean, literally, he can listen to the song like this. We could be driving in the car, a song comes up, whether it's country or rap or rock or 80s, 70s, and he's singing every word. And so we started Googling music and disabilities, and it was music therapy, which is great. Daniel had a music therapist.
Yeah.
But we wanted it to be more.
Yeah, we wanted it to be more group oriented, so that people could be with other people on their own age and their own ability level. And what we found is that's therapeutic in its own right.
And so we realized that if people could come together, they can express themselves, know that they're important, know that they have friends besides one-on-one with therapy. And we've grown from what?
Yeah, we've grown from one keyboard class serving 5 members, and today, or at least we were offering 50 free classes a week to well over 300 members.
And actually, right now, we
Yeah.
have 2 pillars. We have music programs, in person, online, and we serve thousands of people across the country. We have satellite locations in St. Louis, Houston, Tucson, and also Pittsburgh. And we do disability awareness. That's what we do. I mean, our whole life, 7 days a week, centers around that. And this guy's a really good singer, as you know, Christine and Lynn.
Thank you.
It's, we are so happy that Daniel found his superpower, and we think music can benefit
Pretty much anybody and everybody.
including people that don't have aneurysms.
Yep.
Well, thank you both. No, I couldn't agree more. I love to sing and I've got the worst voice in the world and it doesn't stop me. So
I bet that's
better.
not so.
You just got to tune the instrument. That's
Yeah,
all.
yep.
You got to
Yeah.
practice.
Yeah.
I know.
People don't
Thank
realize
you.
a voice is an instrument. I mean, so they
Yeah.
sing once and they say, I can't play. We have an opera singer who's one of our instructors, and he practices hours a day to get his vocal cords and get his breathing going. So, Christine, it's not over yet with singing.
You've never heard me sing. But thank you. So moving on, our next question for Dr. Ubeda. What is the recovery process like for a child post-aneurysm in AVM treatment, realizing that each case is different? What are the greatest challenges? And have you seen music implemented as a recovery tool?
Hello, thank you for having me, first of all. So like you said, the recovery process for a child with post-aneurysm is very different depending on where the aneurysm was, what parts of the brain were affected. Mobility can be an issue, cognition, communication, feeding. So it's going to be very varied depending on the area of the brain. And it's also going to depend on where in the developmental stages the child is, because the recovery is going to be different for a toddler compared to a child who's older, like 10 or 14. And so really depending on what has been affected, we're going to use different types of interventions. We can use physical therapy for mobility, for transfers. We can use occupational therapy for fine motor skills if it's been the upper extremities that have been affected more, and also for activities of daily living like dressing, undressing, feeding. We're going to use speech therapists for communication and also for cognition, neuropsychologists. What else do we have? Musical therapist as well. We'll talk a little bit about that later. So when we start the rehab therapy intervention, it starts in the acute hospital setting. So whether that's trying to help with agitation or with patients who are not super wakeful, we can help there. And then once they're medically stable, they will usually transfer to an acute rehab hospital. And the goal of the acute rehab hospital is to regain as much function as possible and to try and get the child to a close a functional level as they had before, and to try and integrate them into their life back at home. So when they're in an acute inpatient facility, they will receive intensive rehab therapy. So normally you get physical therapy, occupational therapy, and speech therapy every day. There's a lot of education with the family regarding what their new functional level is and kind of what the expectations are going forward. They're provided with all the equipment they need to go prior to going home. And when they're inpatient, the team also helps them set up the supports they're going to need once they get home to be able to succeed. And they will continue working with them in the outpatient setting once they're discharged from inpatient rehab. A lot of the children who've had an AVM will continue therapies in the outpatient setting and outpatient clinics. And also the team will work with the schools because they'll have therapists as well there, and they can, there's the IEPs and the 504s to try and support these kids in school as best as we can so that they are successful and grow up to be nicely functioning adults. What the greatest challenges are. I think one of the questions we get a lot, especially at the beginning, is what is my child going to look like from a functional perspective going forward? And I think that's a really difficult question to answer because it's just really hard to know. And we know, like in adults with strokes, the biggest changes we see and the biggest gains are within the first 6 months. But with children, there's neuroplasticity and it's a little bit different. So we see gains up to 1 year after and even after that. So what the final picture is going to look like is sometimes really hard to know. And then the other greatest challenge, I think, is the cognitive disability. A little bit about what Daniel was saying before, like people see physical disability like when it's difficult for a person to move, but sometimes they don't see the cognitive part of it. And I think that's challenging, especially in the school setting. And then have I seen music implemented as a recovery tool? We use music in the acute medical setting. We've seen music helps calm the patients. It decreases heart rate, respiratory rate. It also helps arouse patients who are kind of in a lower conscious state, playing music that they're familiar with. And then we use it in occupational therapy or physical therapy, either to increase as a motivational tool to increase participation, and also as a tool in of itself, like if they're working on fine motor skills. And it also works with speech therapy, like filling in the blanks, with word finding, with rhythm. So there is a lot of application of music within the different rehab therapies that is super helpful. And there is studies that have shown that you can use the brain processes that music uses for other types of function to recover. So there's a lot of potential there.
Christine, if I just wanted to jump in with one story to add
Yeah,
on.
sure.
When Daniel was in a coma, we would play music all the time. And one night, and we told the nurses, please play music. And we were playing soothing music. Mm-hmm. And the night nurse played disco with a thumping beat. And his intracranial pressure went through the roof. And the doctors came flying in and said, what's going on here? And there was this thumping music. So Daniel responded in his coma to the music all the way through.
That's something. All right, that's great. Thank you for sharing that, Ken. Thank you, Dr. Ubeda. And now the next question is there any research that is specifically targeting pediatrics and/or is general aneurysm AVM research applicable to the pediatric community? And we'll start with Dr. Sasaki-Adams.
You know, I think there's research being done in all realms. I think pediatrics research in general sometimes has a bit more challenges to overcome. One is the smaller number of patients, and that there are different underlying reasons. You know, most 10-year-olds are not smokers, and so you can't have a cohort of smoking 10-year-olds compared to to other folks, thank goodness. And so I think that the population is less. I also think there are more hurdles to jump through from a regulatory standpoint for pediatric folks. We've all seen that with the COVID vaccine sort of delay in the pediatric population. It's very important that we do due diligence and make sure that any research that's being done is vetted before it's on pediatric patients. I do think that there is some overlap, but I definitely think that there is a role for pure pediatric aneurysm research because they are often different type of aneurysms, and we think the mechanism of their development and things are different. One of the more exciting things, I think there's a lot more push to look at the underlying genetics of the aneurysm, and I think we're making headway and sort of figuring out what potential, ideally we'd have a blood test, you take this blood test and, you're at higher risk than you are. So, we don't have to put you through all these other tests. I think that we're getting there, but we have a ways to go. One thing I just wanted to jump back on when we're talking about discussion with family and siblings, whenever I have a patient that comes in with an aneurysm rupture, I always like to let people know we're talking a lot about trying to find aneurysms ahead of time and things, but I don't want any of my families who are affected by this to feel that they somehow missed a signal. I think there's a tendency to sort of beat yourself up about it and say, oh gosh, last week she had a headache, or, she was complaining of something funky. I think it's really hard to go through something like this. And I want people to know that there often is not, there's not a real clear warning sign, and that when it happens, no one did anything wrong or missed anything, and weren't attentive enough to their loved ones. So I think that that's an important thing to take home.
Yeah, thank you. Glad you pointed that out too. That's certainly very true. Dr. C, would you like to add anything to that?
Yeah, I think exactly like Dr. Sasaki-Adams said, sometimes there can be certain challenges in doing research in pediatric problems. If I were to break it down into kind of three broad categories of research, what I think a lot of us think about when we say research is, enrolling in some trial and some new treatment strategy. And even in adult cases, it's difficult to enroll. And a lot of the development is in endovascular or minimally invasive strategies to treat this. So like Daniel got with the coils that Dr. Berenstein did for him 25 years ago, we have new versions and new ways to treat challenging aneurysms. But even in those take years to develop in adults. And now we have 2 to 3 different generations later of technologies to approach aneurysms, but none of them have been tested in children. Even 1990 was when they first really developed good, robust endovascular approaches. Those coils that Daniel had, they were about 5-6 years old. They were not studied in children. That's okay though. We don't always rely on that kind of randomized trial where we have to have thousands of kids to use these techniques. And at Boston Children's and at centers around the country, we have found that all of these tools are translatable. But that means we need to just keep up to date and think about the data for children. But there are 2 other areas where there's significant research, one of which exactly like Dr. Sasaki-Adams mentioned is the genetics. And that's a uniquely robust opportunity in children because as we mentioned earlier, pediatric aneurysms in children, there's a heavy driver of genetic changes that lead to those problems, both for aneurysms and for AVMs. So if we have a better understanding of that, that is going to make a huge difference in how we approach aneurysms. And potentially it may change it from something that's a surgical disease into something that might be actually a medical disease if we understand these genetic problems and can address them potentially early on. And some of the challenges, as she mentioned, are they something that you can do a blood test? But for example, if there's a couple of researchers at Boston Children's, one is Dr. Sid Srivastava, and the other is Dr. Christopher Cayley. One's a neurogeneticist, one's a neurosurgeon who does genetics. And they've been publishing a lot of research recently on different kinds of pediatric malformations, so vein of Galen malformations, which are not really an AVM, not really an aneurysm, but kind of at a bridge between the two. And we're understanding that there's huge genetic drivers, and at least a third of the population, we already understand where those malformations come from. And, I benefit from that because that's the research I'm doing in my lab, looking at those mutations and forming those patient-specific mutations in cell lines so that I can study them under flow conditions and explore how that changes how those lining of the blood vessel are reacting to flow. In addition to meetings like this, the Boston Children's is hosting a Moya and Brain Aneurysm Day on Saturday, May 7th. Some of you may have seen that on things like Facebook groups, but there's a lot of other researchers who are going to be presenting there, both from Boston Children's and from centers around the world. We have speakers coming from Sick Kids at Toronto and Great Ormond Street and talking about what they're doing in terms of imaging research to better understand aneurysms, one of which we're trying to set up here using the 7 Tesla magnet at Brigham, which is clinically available, meaning you don't need to be in a research trial to get a scan on that. But you can look at smaller structure, more refined structure of these blood vessels and really start to think about, are there features that tell us this aneurysm might bleed compared to this other aneurysm? And as we discussed earlier, we don't know which aneurysms in children are going to bleed, even though we have kind of good guidelines in some adult aneurysms, but it's certainly a little bit more complex. And there's a lot of research going on, even though it's not how we treat it. Things like figuring out what the drivers are, things like figuring out which ones are dangerous or less dangerous. So lots of opportunities there.
Thank you. That was great, Dr. C. I appreciate that. So the next question is 2-part. I kind of know the answer to the first part, and I'm more interested in what the feedback is on the second part. Parents and Daniel, do you feel it is important for the foundation and the medical community to do a better job about providing education and awareness around pediatric brain aneurysms? And do you have any suggestions on how we can better do this? I'll start with Todd first.
Well, Christine, you and I have talked about this on and off over the years, that I think really the key to education and awareness is starting with the first responders and the frontline medical professionals. I've told people over the years that we have excellent public services here in the town we live in, and really the county that we live in. And unfortunately, we've had to use them a time or two, so that's how we know that. But when they showed up that morning, there was never any conversation, and I don't blame them for this at all. Please don't take my comments in that way at all. There was no conversation about her brain activity, anything to do with the headache, anything at all. It was really just checking vitals, trying to gather some information. And then, they put her in the ambulance, and I mentioned earlier, we went to Wake Med over on the east side of Raleigh, excellent trauma center, excellent hospital, but no pediatric neurology. So then it was a 45-minute or so drive over to Chapel Hill to UNC Children's. And, we're talking about a health issue where seconds matter. Now, in Ellie's case, it didn't matter. The damage was so severe. I think the estimate we got from your folks, Dr. Sasaki-Adams, it was the size of a plum, and it was on the brainstem. And so there really wasn't much that could have been done about that. And so, but in other cases, that's not the situation. Those seconds matter. And so I think just getting education out into the field to those frontline folks, like I said, the first responders, the doctors, the pediatricians, so that when somebody does present with, an unusual string of severe headaches or the other symptoms that are present, that, maybe that gets elevated on the checklist a little bit sooner than where it is today on the pediatric side of things. And again, I'm not faulting any doctors in our case, because I think everybody did their absolute best with the information they had available. But man, if they just had one little nugget 3 weeks earlier, 4 weeks earlier, well, that might have made a little bit of a difference. But again, being where it was, 3 weeks before she passed away, Ellie was hiking the Appalachian Trail. If we'd have known she'd had a brain aneurysm the way she had one, she would not have been on the Appalachian Trail. She would have been wrapped in bubble wrap in the corner of a room. I'm sure we would have been overly protective. So she got to live her life. But, in other cases where it does present in a way that can make a difference to save lives, then I think that's really important to really find a way to get that message out in a more prominent way than we've been able to figure out today. So,
Thanks, Todd. I appreciate that. And you're absolutely right in everything that you said. So, Daniel and Ken, what do you think? And, you know, primarily, obviously, a better job can be done. So what would your suggestions be for the foundation and the medical community?
I think there's a couple things. I think there's an umbrella, which is stop Googling and trying to figure out what it is. Communication with your child. Daniel said this, and we took him to the ER room, but they didn't do a CAT scan with dye. We think it was the first bleed. You said your head.
Yep. I said it felt like my head was gonna explode.
And so there's a couple things. Number one, parents not doing wishful thinking, but actually seeing medical professionals, understanding their child. That's the key. That's a key comment sentence, right? My head's going to explode. I think education at whether it's first responders or doctors, when they hear that, they should automatically check if there was a bleed at that point. I also think that the parents have to advocate for their children. They have to, the doctors, the pediatricians don't know the personality of the child. And so the parents have to advocate and say, look, my child doesn't complain. When they're complaining like this, you need to do tests. My wife was very good in saying, no, you need to do this now, you know, after Daniel was in a coma. So I think that's part of it. And understanding that there's probability and then there's binary, right? So probability in many diseases works. With aneurysms, it's either yes or no. And if it's yes, there's no time or room for probability. It has to be dealt with immediately. So I think it's parents, I think it's first responders, I think it's knowing your child, and I think it's pushing to make sure that the hospitals and doctors aren't influenced by insurance companies. That we can't do this test because we're not seeing the signs. I think the parents have to say, look, you have to do this test now. I know my child says his head's going to explode, and I don't care. You have to do it. So those are my things. And as far as communication, I think getting the word out about that. There is no room for probability with aneurysms.
All right, thank you. Appreciate that. Ken as well. Todd, the next question is for you. What kind of support and resources would you like to see offered to patients and families who do lose their child?
So Karen is my wife, Ellie's mom. We were talking about this a few days ago as I was prepping this. And, you know, I think that's also probably part of the package that goes out, you know, as part of the education. It's not always, it's probably more than just awareness in terms of what to watch out for in terms of identifying a brain aneurysm or a rupture, but it's also, maybe some identification of resources or people to reach out to or talk to. I mean, not only when they told us Ellie had a ruptured aneurysm, not only did we not know much about aneurysms, we had no idea the Brain Aneurysm Foundation existed because we hadn't been affiliated with anybody who'd had one of these, like other than her great grandmother, as I said. So the morning after she passed away, we were starting to write her obituary, and like people will do, want to give people an opportunity to donate with flowers and things like that. And so I Googled Brain Aneurysm Foundation, and I found the Brain Aneurysm Foundation. And so that's kind of started our relationship with Christine and some others who fight this battle on a daily basis. But I think it's really, what are the you have a wealth of information on your website and such about educating what aneurysms are, and I think that's still important. Even if you've lost a loved one to an aneurysm, I still think people still want to know more. They want to read it and familiarize themselves with it, because you don't know who else might have it in the family. You want to know what to watch out for. I think it is, and I think it is important for people to understand the kinds of resources they have available to themselves for testing and for what's being done with research. And again, those are all things that are available. I think we just need to figure out a way to make that an easier access, because not everybody may Google Brain Aneurysm Foundation. And also, as I tell people who have health issues, that Google's not your friend. But in some cases like this, it is, because then you find out, after the fact with Ellie, that what we were dealing with and what that looked like and what we needed to watch out for ourselves with Grace and Anna. And we all get scanned. We all have MRAs probably every 4 or 5 years because of the history in our family. And I think it's just as what comes next, I think, is really the important thing too for people, whether they've lost a loved one or whether they have a survivor. But what comes next, and how does this extend out into other family members and such? Because I think knowledge is power in those situations, because they can get some absolutes in terms of what to look out for when they are, because we all feel guilty. I think probably part of Karen and I will always feel guilty that we didn't pick up. I mean, we're mom and dad. We bring these kids into the world. We're supposed to protect them. I was doing CPR on that kid that morning when she was having breathing issues and such. I mean, I told somebody that later, and I'm dad. I'm supposed to protect her. I was trying to protect her, and look what happened. And I get that at a fundamental level, that I couldn't do anything, but still, helping people understand those things, the definite things that happen, and trying to make sense of what has happened as best you can. I think those are the resources that, and I don't know what that looks like, and I don't know what the distribution channel is, but I think it's important that we try to do those things.
No, thanks, Todd. That's very insightful and helpful. It's definitely not easy. And yet, what are the answers? We don't know 100% now, but that's why we're talking, and we want to figure things out so things are better down the road. So now, same question, Ken and Daniel, what kind of support would you like to see offered to patients and families for when their child and patient is heading into recovery?
I think the first thing is for people to read the families and for them to understand where they are in the cycle of newness. I think I would have appreciated someone saying your life, even if Daniel has a full recovery, is changed forever. Okay? Just come out and say that. Because in Daniel's case, he had a lot of challenges he worked through. He's done remarkable. But schools are going to be different. Friends are going to be different. Passions are going to be different. Capability is going to be different. And not to try to bring the child back to the day before the rupture. I was guilty of that. I researched so many things trying to bring Daniel back to March 8th. And Daniel, in his ever wisdom and sagely wisdom, remember what happened when I was doing therapy?
Yeah, my dad was helping me with therapy, and he was telling me to kick my right leg through, and I had a sad look on my face, which isn't very often with me. But in any sense, I told my dad, I want you as my dad, not as my therapist. I have tons of them. I only have one of you.
And so for that was groundbreaking. And so to accept the new child, to love the new child, to look for something that's meaningful for your child, that they love, not what you want them to be, is what I would say is good advice coming out of the hospital. And to accept that things are going to be different.
Would you find help for people bringing food and help?
Thank you both. That was very great. I appreciate it. And I know it's hard for you guys all to go back, for Todd to relive this, and for Ken and Daniel to go back. It's hard to do that. So I appreciate you both being willing to share this with everybody. So the last question is for the medical professionals, and so how do medical professionals feel that you and your facility can do at providing support for the pediatric brain aneurysm community in loss and recovery? And what changes would you like to see, and how can the foundation help? And we'll start with Dr. Ubeda first.
I think in the last few years, we have started to talk more about functional loss and expectations from an earlier stage. I think there's a growing presence of pediatric rehab doctors that there wasn't before. And so I think they're bringing this discussion in earlier, and they're also starting the rehab processes earlier. And the sooner you start, the bigger the gains are. So I think in general, we are headed in the right direction.
Thank you. How about Dr. C?
Yeah, I'm very fortunate to get to work with expert pediatric rehab doctors like Dr. Ubeda. So I already have lots of resources at my disposal to help patients and families in the recovery process. And, our neurointensive care unit has specialized nurses who help and facilitate conversations whenever there's a question of if someone's going to survive the brain aneurysm. And we have a dedicated care team that, has those conversations and helps guide families through that. I do think that in the broader scheme of the recovery and involvement in the community, obviously the Brain Aneurysm Foundation is in a uniquely leveraged position because they can connect people that otherwise wouldn't have that connection. So for example, how Todd, found more people to work with and discuss these considerations and to advocate for patients who don't even know that they have brain aneurysms yet. So leveraging that to potentially be kind of a home base for some research projects. Obviously, you already fund a lot of research, but being the center for example, pediatric registries, so that we can all be enrolling. And I'm doing some work with those other groups at Sick Kids and at Great Ormond Street and at UCSF to create a registry for pediatric aneurysms. But we can't reach every single patient. But I think a lot of them will come through the Brain Aneurysm Foundation, and that means figuring out if they are wanting to contribute information for genetics research or get even more involved and be participating in the thought process of research itself. So there's certainly some meaningful engagement that the BAF can facilitate there.
Great, thanks, Dr. C. And Dr. Sasaki-Adams?
I think I feel that from a neurosurgery standpoint, we're often there in the very acute period, and then we see people in clinic a little bit, in follow-up. But it changes people's lives, and they need, there's ongoing shifts, and they might not have been ready for intensive rehab when they left the hospital, but 6 months down the line, they're ready to go. And it would be helpful to have more access to rehab specialists aside from when they're an inpatient, and sometimes that can be a bit challenging. So I think the more we can work on the whole team kind of umbrella and making sure that this is a path that we're kind of all on together, I think would be useful. And I think, the Brain Aneurysm Foundation, every, tertiary care hospital, and like the rise of pediatric neuro rehab specialists, I think is also helpful. But I'd like to see that spread out even in, rural North Carolina where there's not a lot going on, but it would be nice to be able to have that opportunity. As far as when people lose someone, that's it's really difficult. And I think it's it's not the kind of thing that you necessarily have a follow-up, visit for, but you can, I've met with families and things and answered questions afterwards if there are those. But I think having it be accessible for those, these kind of webinars, this opportunity to ask those questions and to bring light to it, I think is really valuable and important. So, yes.
Yeah, no, that's great. Thank you, Dr. Sasaki-Adams. And I'm going to have Lynn read the questions. There was one for sure in the chat, but if anyone else also wants to, continue to put something in the chat, please feel free to do that.
Yep. So the one question we have so far is from Jessie Lee, and it says, my mother had 5 unruptured aneurysms when she was 42, had 2 successful surgeries, and is still with us. Given the familial component, I am checked every 5 years. However, I am now 42 and have 2 boys, ages 12 and 14. Should they be screened? If so, when should it start?
Who would like to tackle that?
I think screening, as we kind of discussed here, is always a tough question. And there's never an absolute right or an absolute wrong. And it sounds like, for example, Todd and his family have kind of set up a plan with their doctors. So if there is a significant family history, it certainly is often appropriate to discuss with your doctor as well. When should they start getting screened? And I think personally, if I'm talking to a family with limited information kind of just from this question, it doesn't seem completely unreasonable to get one set of baseline pictures as a child. But if there's absolutely no abnormalities of the vessels there, then I might wait until they're adults, because it may be that your mother had, adult type problems, and maybe we don't need to be worrying as much when they're younger. If again, we've confirmed that, hey, there's nothing at this baseline. That being said, I certainly can be completely wrong, right? But that's kind of my general guidance in that kind of scenario. But I have conversations and an actual visit with people to discuss it through, to figure out why are they concerned and what level of concern I would have if I were in their position. I think I actually see 2 other questions also. So maybe I'll give Dr. Sasaki-Adams a chance to answer this one, but we can discuss the other ones too.
Yeah, I would agree. It's if it's a pediatric aneurysm, I definitely would say they need to be screened early on. Adult onset aneurysms or diagnosed aneurysms are often behave differently, so they're not necessarily the same. In my adults that have aneurysms, I recommend that they get a screening MRI when they are kind of more adult age, usually 18, 21, and then kind of go every 5 years or so from there. And, sometimes honestly, it's also peace of mind for people have gone through a very dramatic, life-changing event, and to know that their children, other children are okay. I think it's very valuable to be able to get that screening test and know that there's not a monster sort of lurking where you can't see it. So, yeah.
Question.
Well,
We have, sorry.
Oh, yeah.
One says, I'm not sure if I missed this earlier. My question is for the doctors. Would be when their recommendation is for children to be tested for aneurysm with family members who have been, I think we just answered that one.
Yeah, I think kind of to be very precise about the answer there is, if someone in the family has an aneurysm, you should definitely have a formal discussion with your doctor. And, it might involve actually a formal discussion with your pediatrician or your family doctor. And if you're not satisfied with that, maybe you do need to talk to a neurologist or a neurosurgeon just to make sure that you feel comfortable with that answer. And that's going to be because each answer needs to be tailored to what were the conditions that led to that aneurysm. For example, smoking history, as we discussed, is a significant driver in certain adult populations. So if that's present, maybe we don't feel as concerned about a child having an aneurysm, but we need to recognize that when they become an adult, those same risk factors can drive them to have that risk. So that needs to be a nuanced discussion. Yeah.
Someone else asked, should I seek an MRA every 5 years, even if nothing was shown on the recent one? So I don't know if one of the doctors wants to answer that.
I think it's reasonable. Aneurysms take time to develop. So I have folks that are very anxious about their aneurysms and they would like to have an MRA every month. But I say, don't do that, because even if something's there, we're not going to be able to detect it. It takes kind of years for that little bubble to expand. And so, I think if the first MRA was clean, it would be very reasonable to get another one in 5 years. I think the time of it being just never get checked again, I think
I'm going to now.
Not there anymore. I think our tests are, getting better and better. And you might, sometimes they'll get an MRA and you won't be able to, there's different degrees of MRA. Some are better than others. And so some people with very small aneurysms might get said, "Oh, you might have an aneurysm," and then they get another one in a year and it's gone. And it's just a level of the test. It doesn't mean your aneurysm is popping up and going away or moving around or anything like that. It's just our ability to detect it in the view that we get. So.
Okay. And then there's one more question for the doctors. Is there a connection between Marfan syndrome and aneurysms?
Yeah, I think we all believe so. I don't think it's necessarily the highest risk of having an aneurysm. There's lots of Marfan's patients who don't have aneurysms, but the risk is certainly higher than someone who doesn't have Marfan's. So, yes.
All right. Well, I don't see any more questions. I did see some nice comments there for sure. I wanted to say thank you so much to all the panelists for, again, sharing your expertise, your stories. This obviously has been recorded. We're definitely going to share it. And hopefully this group can stay together to, keep trying to get the awareness and education out there for the pediatric community. We need your help, that's for sure, here at the foundation. We need your ideas and suggestions. And anyone have any closing remarks that they'd like to share?
I wanted to say just a few things. First of all, Christine, thank you for bringing everyone together. Really appreciate it. It was fantastic. I learned a lot. To the doctors, I would say thank you and never give up in having a patient survive. Daniel's had a beautiful life.
Yep, I have.
And sometimes, even if you're looking at, challenges, he's a person that loves life, helps others. And so if you have a doubt, what have I helped? You've helped a lot. So keep that going. Thank you.
Thank you, everybody.
All right. Well, then I guess it's a wrap. Thank you all so much. And look for the recording and share it, please. Take care. Bye-bye.